Thank you for joining us. We know many of you are still evaluating the new LEAD model, and the application deadline of May 17th is approaching fast. This session is intended to focus on practical guidance from those navigating the process themselves or helping others to do so. Before we dive in, a few quick housekeeping notes. Today's session is being recorded and will be available and will be sent to you via email. Thank you to everybody in advance who submitted their questions. We have worked these into our discussion for today. We encourage you to continue to submit questions via the chat throughout the session, and we'll aim to answer them live. But for any question we don't get to, we will respond via email following this session. With that, I'm happy to welcome our panelists for today. We'll do a quick round robin of brief intros, and then we'll dive into the session. Theresa, can you kick us off with a quick introduction, please?
Absolutely. I'm Theresa Dreyer. I'm the CEO of the Healthcare Transformation Taskforce. We are a multi-stakeholder collaborative based out of DC and focused on value-based care. So we bring together providers, payers, employers, and patient advocacy groups to collectively advocate to our national policymakers about how to improve and both policy and practice the value-based care models that you all are participating in.
Fantastic. Thank you for being here. Steve, over to you.
Yes, hi, Steve Carson here. I am the Senior Vice President for Population Health for the Temple University Health System. In my role, we're responsible for all the value-based care agreements that we have with third-party payers. We are an ACO REACH organization with a relatively small beneficiary patient population with our employed providers. And we also have a division that focuses on community outreach, social determinants of health, and addressing those issues among our attributed patient lives.
Thank you, Steve. Appreciate you joining us. And lastly, Bridgette.
Thank you, Les. So, Dr. Wiefling, I am the Chief Medical Officer and Chief Transformation Officer for Cope Health Solutions. Got 25 years of executive experience across the continuum. Most recently, I have been on the plan side, but certainly my expertise is in the development and establishment of value-based care contracts, clinically integrated networks. How do you set up for success, both on the clinical and the business side? So excited to talk about LEAD today because it's a really good opportunity.
Wonderful. Thanks, everyone. My name is Les Duncan. I'm the Vice President of Value-Based Enablement at Cope Healthcare Solutions. Let's dive in. So, Theresa, let's start with you. In your role at the Healthcare Transformation Task Force, you've participated in a number of these discussions, including most recently at NACO's Spring Conference. What are you hearing that organizations are most excited about? And where are you seeing new opportunities that perhaps didn't exist in previous models?
I think some of the things that are most exciting are things that carry over from REACH, such as the global risk opportunity and the fact that the primary care capitation creates upfront cash flow. Collectively, these two things mean that an organization that is ready and able to bear that level of risk gets first dollar savings on on the savings they achieve with their attributed beneficiaries. And the primary care cap with the cash flow means that you don't have to wait 18 months for your reconciliation. You have dollars in hand that you can use to invest in your care delivery and in your patients. One of the new things that I think is most exciting for a lot of ACOs is the fact that the high needs beneficiaries are so incorporated into all LEAD ACOs, as opposed to in REACH, where that was not a component for the majority of LEAD ACOs. You had to be in a high needs REACH structure, but now any of your patients that would meet those qualification criteria have their own risk adjustment, have their own target prices. And so every LEAD ACO is going to have the opportunity to engage specifically with that patient population with new tools and resources to support the care that they need. There are two other things that I think are nice carryovers with some growth opportunity. You have the new opportunities for specialist engagement, in particular the CARA, the CMS administered risk arrangements, which are essentially nested bundles. You also have choices such as non-primary care cap that you can use to subset a group of your specialists and pay them with capitation or advanced payment options, which again creates cash flow. These are tools that are optional but available under LEAD and are not available in any other ACO model out there.
Steve, how does that resonate with how you're viewing the opportunity at Temple?
So many of the things that Theresa just mentioned are really at the top of our list. I think when we look at LEAD going forward. Probably the most significant item that we are really focused on is how we manage our high cost patient population and the high needs beneficiaries and where they fall within our workflow. And the other piece is really that we did not take full advantage of under the ACO REACH is the specialists, and that non-primary care cap is really something that will be helpful to engage our specialists. And specialists that we're looking at are like cardiology and pulmonary, who have a tendency to have some more chronic care patient population, and really could help benefit the overall bottom line of the ACO. So they're probably the most important things that are new that we're interested in looking at, is how we develop and look at what we're going to do as our next steps.
Excellent. Steve, let's stay with you for a moment. Like others on the line, you're a current REACH participant. What lessons have you learned in the REACH program that you'll carry forward? And what feels like a natural continuation versus a major shift in looking at the move from REACH to LEAD?
Let's unpack that a little bit. It's a lot. So things that we that we're going to carry over that I think are really critically important is really how we focused on the quality and the quality metrics, and even moving forward in how HEDIS measures will eventually be tied to the overall quality outcomes are really critically important. We learned a lot of lessons there and the value of the quality metrics. And also with the addition of the HEDIS measures, I think that would be a really great opportunity for us. There are areas we're already focused on because we have other value-based care agreements that tie those metrics in. So we think that is really something that we will carry, that the quality component and the work related to HEDIS will carry over and really benefit our beneficiaries as well as our bottom line going forward. I think from the other area is really the beneficiary enhancements. We utilized a lot of those enhancements. Primarily, we used this skilled nursing 3-day waiver a lot, but there were other enhancements that we may not have used as more detailed as we should have. So when we look at those benefit enhancements, looking at home care and how that will make a difference, telehealth and the hospice, how those things will make a difference for us, those enhancements are really going to be important going forward.
So I'm going to ask you a question here also. The 3-day SNF waiver, what was your experience with that? Is it, you said you use it a lot, is it something that's fairly easy to put in place, or is that quite a lift for you?
It's a lift because you have to look at, so you have to maintain your STARS level with the nursing homes. So we had over a period of time, homes meet the requirement, homes dropped off. So that was something that we have a whole monitoring process built around. We created a SNF collaborative and a network. So it was work to kind of keep all those pieces together. And we also provided our SNF partners with feedback with regards to length of stay, readmissions, and patient feedback. So it's a little bit of a lift, but well worthwhile if you're able to capture that patient early on prior to even being admitted. So we use that periodically as our nurse navigators are working with a primary care provider, and the physician wants to send the patient to the hospital, and the nurse will remind the physician if it's hydration, that could be done in our nursing homes rather than going into the hospital. So we've used it in that way, relatively small. A lot of times we'll capture the patient when they've arrived to the emergency department. So we've used it in that way, but it's something that everybody has to be focused on. The nurse navigator, we have a contact in our emergency departments, we have a nurse there, and we also have someone who case manages all our hospitals overall to say who's in, to make sure that we are able to apply the different benefit enhancements. So it's a bit of orchestration and work.
Great, thank you. Bridgette, you've been on the road meeting with ACOs evaluating MSSP versus LEAD. What are you hearing from the field?
Yeah, I've heard a lot of the things that I think Steve and Theresa have been talking about, lots of buzz. I do think there are some concerns people are worried about with respect to, especially, the high risk the providers that have a high concentration of high risk and duals are sort of feeling like, how do we know which state's going to be chosen? And, what happens if if our state gets chosen? How does that impact us for the duals pilot? And a lot of confusion around the financial modeling and if an entity would be considered, a high risk entity or high cost or low cost. So just trying to, figure out the numbers and the math on that. And then certainly the move towards a rate book methodology at that half point of the model is creating a lot of consternation. So those are things that I think we should think through and be able to help explain.
Yeah, we've received lots of questions on those same topics. Let's try to unpack these, like I like to call them unknowns. Let's start with the questions around the rate book methodology shifts. Steve, would you like to take that one?
Yeah, from a rate book perspective, I actually, because it's unknown, it is really the modeling of that's really the struggle. So in understanding, where you are today versus that retrospective and prospective view, depending on whether you're a new ACO or whether you're a ongoing ACO, I think is the piece that we're all trying to understand what that means to us. So I think at some level, the rate book for me is a little bit more comfortable because they're going to create that rate book. That's my impression, at a time where we all understand where we are, how we're acting, and what, how we are actually producing. So in a sense, even though it's uncertain in the beginning, I think the rate book will be a little bit more comfortable, a little bit more predictive. And I think that will be helpful as time goes on. But I think I can see the area of just why people are uncomfortable, because we're uncomfortable trying to figure out where we benchmark ourselves and how we look at it.
Steve, do you think it's fair to say, and maybe it's not, so please be honest, that you can sort of think about the rate book a bit as a bell curve and getting graded on a bell curve?
Yes, you're
Yeah.
exactly right.
Thanks. I think that will make people feel more comfortable about taking a leap.
I mean, because that's why it's in the beginning, it's like you're creating a benchmarking based on your region and things like that. So I think you're already, working your way towards it in the first place. That's giving you a little bit of time. The uncertainty is how do you do that calculation and where do you think you're really going to land to say, this is how I want to go? Because it's 10 years, right? The purpose of this is longitudinal long term, and there's a penalty for leaving early. So, you're trying to figure out where you lie.
Yeah, and I think, important to note is that as we have all grown and learned a lot more about managing under value-based contracts and doing population health effectively, I think CMS has also learned that's evident in LEAD, that they have taken a lot of the best from the best. And I do think that there's been, there was a great learning for CMS when the ACO Next Gen kind of had an epic fail out of the gate. And what I'm hearing from CMS is that they do not want that with this.
No.
They are looking for this to be successful. And so I do feel like there is a bit of give and take on this one, that they're going to have a close ear to the ground to make sure this is successful. So that, from my vantage point as a provider leader, gives me a lot more comfort.
Great.
Theresa, you have any thoughts on some of those other unknowns we talked about?
Absolutely. I think I'd like to pick up on the uncertainty that Steve raised around the high versus low cost ACO, depending on your region. And I think a lot of ACOs, if you've been in any ACO model in the past, you probably have a sense of whether you are considered a high or low cost. There's been other delineations like this in other models. I think what's tricky about this one is that your previous heuristics may not apply as to whether you're high or low cost because of the introduction of the high needs beneficiaries. And I think that's an important point to notice. If you think that you are firmly on one side or the other, maybe you still are, but maybe you actually do have a different proportion of high risk beneficiaries than your peers in your region. And if that's the case, that could really flip what category you're in. Specifically, it's because the way that the methodology works, historically, ACOs had two populations, aged and disabled and ESRD beneficiaries, and there'd be risk adjustment within that, but it was two groups, and then you'd blend them. ESRD is a pretty low volume group, and so it was mostly aged and disabled. What's different here is that there's a carve out from the aged and disabled, which is the high needs beneficiaries. And so your high needs beneficiaries are going to have a different risk adjustment methodology. It's the risk adjustment methodology that was first tested in the REACH high needs track, which is concurrent. So you're not doing a year look back, you're doing this year's diagnoses. And it's the kinds of things that people don't generally just fully recover from. These are very high cost, high needs patients that have severe illnesses and have high utilization patterns. And once one of those patients meets the criteria for being in that group, they stay in that group for the rest of the model, but they're carved out from the A and D population, the aged and disabled population. That stratification makes the math a little bit more complicated, and we don't yet have the detailed financial methodology from CMS. So in the modeling that people are doing, the modeling that many of you are probably doing, you're making some assumptions about with the data that you have, and you can probably get a pretty good guess of where you are, but there are some assumptions built in because of the lack of information from CMS about that. So I think that is one of the biggest points that LEAD participation hinges on, since that designation of high or low cost comes with very different financial incentives. And then compounding that, you have the rate book methodology that Steve mentioned, and you have the introduction in year 3. After the first 2 years, you have the introduction of AI and first inferred risk adjustment, which will be one component of the risk adjustment methodology, and we have not yet seen examples of that in any existing models. So while CMS will be testing it before it's implemented, there's a lot of unknowns there that I think make ACOs nervous just by nature of the fact that uncertainty itself is stressful.
I think on the ACO LEAD application, I changed my answer to that question. Are you a high cost ACO 3 times? And I still haven't finished. But it's really just based on like evaluating, what I know now about my ACO patient population. I'm in Philadelphia, which is a high academic, hospital-based health systems who typically have higher cost in the first place. So I can maybe infer that I'm higher cost, but I don't really know the answer and I won't know it for a while.
Yeah, but in the application, right, you can choose, and there's no like negative penalty for being wrong, right? CMS is going to do the calculation at the end, and then you kind of find out after the fact. So I probably would, based on your situation, I would probably put in that I'm high cost and then just see what happens.
That's kind of where I landed, but
yeah,
but it was
exactly.
So I changed the answer a few times, but to be maybe more specific. This is what I think and why. Why am I thinking that way? So it's gotten more specific as as I wrapped up the application.
Well, that was a good topic. Let's go to a question that was submitted by an attendee. Bridgette, I'm gonna ask you to take this one. Being the clinician on the table here, how will LEAD change the way high needs or complex patients should be managed?
Oh, that's a good one. So I think it is far more critical in this version than in some of the other versions that you get it right. And the first thing is identifying them. So I think it's important to have a good ID and strat sort of technology that's going to help you sort through the patients and identify the ones that are high risk and quickly, right? So not sort of by the end of the year, but as soon as you're able to get your arms around the data and get it ingested, you really have to be running your stratification to identify who's going to need intervention more quickly. And I also think, taking advantage of those, of the waivers is really important, and figuring out, which patients will benefit from which programs, specifically when you look at access, and some of those programs that clearly are being touted as important. I do think that being able to understand how you're going to integrate those programs into your management, the clinical management of the patients is going to be important. I do think part of the name of the game on this one is also patient engagement, which was a little less prominent in some of the other ACO models. So I think having a technology platform that's going to let you risk stratify, assign patients effectively to the right kinds of care management programs or right partners. And I think, being able to track those patients efficiently and effectively is going to be important, and engage them through some type of a patient engagement application. I also, I think it's going to be more important than ever to be able to have EMR integration under LEAD, to be able to be working towards that, so that you have the information getting to the providers in a meaningful way, because this is meaningful risk, albeit not a showstopper risk, but it is meaningful risk, and you're going to want to do well on it. And the last thing I would say is, don't forget about appropriate documentation and coding, because I do think the AI component is going to add some new dynamics to that weighting system. And it's going to be important that you have some technology and provider prompting and decision support to help your providers to be able to code effectively. And so, really looking at your platform and making sure you've got an optimized platform, I think it's critically important.
Thank
I'd
you.
like to build on Bridgette's comments about technology, because living where I live today, it's really critically important to have that technology out there. So, for example, we have a health information exchange where we've loaded all of our high-risk patients into that health information exchange. So we now know they're either in our system or somewhere else around our area in another health system's organization. So that's really helpful for our nurse navigators to begin doing outreach, working with case management departments at other facilities. And I think, go back to patient engagement, we rely heavily on our, we have Epic as our major EMR. So we rely a lot on that portal to share information with our patients, self-assessments, satisfaction. So we use that a lot. And then that connection out in the community is really also important, linking when we work with our SNF providers as well. So I think that technology piece can't be underrated. It's something that's really critically important and sets you up for success.
Yeah, I agree. I'm pretty excited about our, new stratification methodology, because the other thing that I have found over the years, is we sometimes are flagging patients that definitely in the moment feel high risk, but over time they would have got better anyway. And we spent quite a lot of time managing them, and they were really a population that we probably could have done more coordination rather than actual care management. And so, having sort of that, having a lens in our strat model that helps to, sort that out, I'm really excited about. I'm also very excited about the incorporation of the SDOH needs. And we've, worked hard on a methodology because you don't have the claims out of the gate, right? You have to be able to identify some of this stuff without having claims. And so I'm pretty proud of what our team has done there, as far as being able to pull in from a variety of places some information on SDOH that I think it's going to give us a lift. So I'm pretty excited.
Yeah, and I think it's really about identifying the rising risk folks, trying to get those people not to hit the top of the cost pyramid, right?
Absolutely.
And insights that you can gain there from your platform that you're using to do your analytics is very valuable. So you're focusing your limited resources in the right places. Those are great comments. I'm going to take a question that's coming off from the participants, and I'll throw it open to whoever wants to speak first on it. If you had 6 months to prepare for LEAD, what would you prioritize? Because that's about where we're going to be once we're accepted. You're going to have 6 months to get ready. What would you do first? Like, what would the priorities be? Steve, you want to take a shot since you're...
Yeah, I'm sitting here thinking of which one would I do first. I think that the financial modeling is probably the first thing.
Yeah.
Since I'm coming from, working in Reach, like I build an infrastructure. So the infrastructure is, I may have to tweak it and modify it a little bit just to maybe to address high risk patient population. But in the first 6 months, I want to understand the finances and what I need to do to be able to manage within in that particular rate and what the quality impact is. And I would spend my time there. And then also after that, understanding the different benefit enhancements and how they could help and build upon your existing platform. So I would pay attention in those 3 areas. That would be my initial focus.
Yeah, I can jump in. As a provider, I would actually also want to be starting early with my provider network group. So who's in, who's out, do they understand, are they engaged? LEAD is going to require that you have an engaged group of providers that want to grow with you and are excited about it. So I would really want to start with that. And I also, obviously I'm pretty pro data. And so knowing how long it takes to get that, to get data in aggregated and ready for prime time. I think, I know we do it pretty quickly, but there are others that are maybe, struggle a little bit more with getting that data in. And so those are the 2 areas that I would also want to be hitting hard. The clinical programs can come a little bit later from my perspective, because you're going to have time once you know who your doctors are, you know who the patients are, you've figured out where they're going to go. You have a little bit of time to get them into clinical programs and get them engaged. So that's how I would kind of think of things. And I fully agree that the financials, as soon as you know your provider network and who's in and who's out, the modeling is key.
Yeah, and I think actionable data, right? It's not just data, but it's actionable data. Some things are nice to know, but what do you actually do with that? So if the information leads you to action, I think that's a really important part of it as well. Theresa, I know you've been out talking to lots of people asking you questions about this. I'm curious what your point of view is.
Well, I think the other panelists covered it very well. And I think by order of priority, I would say financial modeling and provider network. If for some reason you already, say, like Steve, already have clinical programs in place, maybe you already have your provider network in place if you're coming straight off of REACH. Maybe the next on the list, or depending on where your starting point is, I would focus really heavily on those high needs beneficiaries that potentially you probably already have care management in place for your highest needs patients. This model in particular will sort of give you a more bang for your buck on caring for those folks, because they're always your highest cost patient populations. Second, because making sure you've appropriately documented that fact will meaningfully and materially change how that benchmark is calculated in a way that's much more favorable to you because of the concurrent risk adjustment. And some of the things that trigger that designation are based on, inpatient admissions and things that will be automatically in the system. Others are condition based. It's about what types of polychronic conditions the patient is experiencing. And so that I think becomes a very high priority for the first year, even if it's not, the first thing off of the gate.
Great. Another one off of the participant line here is, as you evaluate LEAD, how is your thinking about TIN participation changing? That's probably a Steve question because you're living REACH now.
Yeah.
Are you rethinking how you handle TINs at all based on the new program?
So we were. So we were preparing as an organization. We knew that we were considering MSSP or whatever the next iteration of REACH was going to be. So as we considered MSSP, we already knew that was TIN based. So we were looking about who's in those TINs. Do we want to organize all of our primary care providers who are in the employed group under one TIN? What is the impact of all the specialists? Because we have a specialty network. And then we also have a federally qualified health center and some other outside primary care physicians. So we were like going back and forth. And I think even though it's TIN based, I think the opportunity really lies with who is your preferred provider, who is your participant provider. And I think that really makes a difference. So trying to realign TINs, we kind of backed off of that just based on that fact, but it wasn't really necessary where we thought it was at the time.
Anybody else have a thought on that?
I would add to that for many of the ACOs that I've been speaking to, whether they're a health system that might, have multiple ACOs within the same system, possibly because they're very large, multi-state, or whether it's an aggregator or an ACO working with an aggregator, under REACH, there was probably more thought put into, because you were able to split TIN, there was probably a lot of thought put into that, which is now no longer available to you. And so there's some reshuffling of the deck happening in terms of like how ACOs are being defined. A thing I would just point out for folks is one of the things that I did not initially understand when reading the RFI and has since become more clear from follow-up with CMS is that every year your designation as to whether or not you're a high or low cost ACO is reassessed, but it's reassessed against your baseline. So it's not reassessed based on how you performed last year, or the year before that, or anything else. But if you change who is in your ACO, if you change the TINs in your ACO, it could entirely flip your designation, either from low cost to high cost or vice versa. And I think that's an important thing for folks to understand as they are currently going through the process of defining the TINs in their ACO.
Okay, so I'm looking at the time here. It's pretty much flown by. I know there are questions in the chat we haven't gotten to, so our team will review those and provide guidance and a follow-up note to everyone who registered. Before we wrap, I'd like to invite each of our panel to share a final reflection or takeaway for the audience. Theresa, let's start with you.
I think this is a really exciting program that could be a very good fit for many ACOs, and in particular, some of the flexibilities around beneficiary engagement, specialty engagement, risk, upfront cash are all unique features that could make this the right fit for your ACO, combined with some financially modeling to pressure test that. I think the uncertainty that we discussed previously is a big variable that's out of the control of the applicants and the ACOs. And I've spoken with a lot of ACOs who've said basically like, I would like to join LEAD. I think this is probably the right model for me, but uncertainty has a cost. And the longer we go without more detail, I might end up flipping to MSSP. So if that is that, I think that's a consideration for a lot of ACOs, probably for a lot of the ACOs on this line. And so, we and many others continue to tell CMS this so that they will hustle, as we have seen them do in the past. But I think that's the biggest uncertainty around this first year participation.
Great. Steve?
I'm going to jump on to Theresa's bandwagon about the uncertainty, because I think as you look at the ACO LEAD and MSSP, as we go back and forth and compare what is a good opportunity for us, it is that uncertainty. And, given today's, healthcare environment, looking at what the impact is of HR1 and other things that are going to happen in healthcare, looking at this carefully and picking the right one is going to be really critically important from an organizational perspective. So for us, we're looking for some level of certainty. So that kind of leans us to one direction versus another. But we really, before we do a final decision, we want to be able to understand, what that opportunity is, because there are a lot of great, valuable things in this model when you look at it. So you have to really, go back and look at the clinical model, the different benefit enhancements. So I think there's things out there that really could make a difference in how you deliver care and how you take care of the high needs populations that'll be in your risk pool going forward. So, but the uncertainty piece is really something that, resonates with us as an organization.
Mm-hmm.
And Bridgette, you want to bring us home?
Yeah, sure. So I am very excited about LEAD. I think that it has a number of the levers that will allow an organization to really get their arms around a population and manage it as a network. And I think the ability to now engage the specialists differently than I think, just episodes, so to speak, is really a great opportunity to create a 360 program for managing, your highest risk patients, and patients are going to benefit from it. So I'm really excited about the clever concepts and programs that are going to arise from this as as it evolves over the next couple of years, I think it's going to change the way in which larger networks think about populations and management and contracting. I think it's going to impact the way health plans think about their value-based contracts, and I believe and hope, for the better. So I remain very hopeful around the impact this has the ability to have. And I think the last thing I would say is, if you're not in an MSSP or you're not intending to go for LEAD, you really need to think hard about how you're going to get yourself ready, because I do think that CMS is moving more quickly. CMS, CMMI are moving more quickly than I have ever seen them in my, entire career. And I do think in the next few years, everything is going to be different. And I do believe that the fact that they've been saying for a really long time, we mean it. We want people in value-based care. I think they mean it. And if you're not jumping in and figuring that strategy out for yourself and for your community and the patients that you serve, you are going to fall behind the 8 ball and likely force yourself into a situation where you're part of a group that you might not have intended to be part of. So I do think it's really important to have a strategy if you haven't chosen a horse yet.
Those are all really good insights and final thoughts. I appreciate each of those. I want to say thank you again to our panelists for joining, sharing their experience and expertise in the conversation. Thanks to all of you for joining us and sharing your questions and thoughts. If you'd like to go deeper on any of these topics, I'd welcome the opportunity to connect. Our team is working with ACOs nationwide as they evaluate their next steps, and we're happy to be a resource for you as well. The info to connect to us is on your screen. We'll be reaching out with a recap of today's session. We appreciate you joining us and hope this was helpful. Have a great rest of your day, all. Thank you.